Hello everyone, welcome to part two of this lecture on terms of developments in health policy and looking at some of the institutional and issues and managerial issues as well. The first part of the talk focused on how do we conceptualise change and how do we understand change from conceptual perspectives, including looking at health policy in terms of developments towards systems thinking about institutionalist ideas. We also looked at other perspectives like governance and more structural aspects of how we view change. This part two is going to focus more substantively on thinking through ways in which we can understand developments in health policy from more of a managerialist orientation, from more the kind of managerial lens, if you like. And now that's important because if you want to understand public sector reform and the ways in which reform happens, including in the NHS and in other health organisations and within the policy sphere, it's important to be able to think about public policy from the perspective of managerialism linked to ideas to do with new public management. But before we come on to talk a bit about that, it's important to highlight that the landscape of health policy, when we think about it from a systems perspective, is quite diverse. But there's also a degree of divergence, if you like, with regards to how health policy is implemented and the different ways in which the system works across the UK. So although, for instance, I'll give you we're using the example of the NHS here. When we think about the NHS, we refer to it as a national health service. But actually, contrary to its name or denomination, it becomes increasingly unfeasible to view the National Health Service as an organisation that features an aligned UK-wide reform agenda. So if we're thinking about developments in the NHS, how do we understand its developments without understanding how it actually works? The NHS illustrates a microcosm, if you like, with regards to the complexities that lay beneath the surface of broader public sector reform more generally. So the organisational and structural realities of the health service vary considerably across the component parts of England, Wales, Scotland and Northern Ireland. And Doheny 2015 documents this really well, and there's a reference to that work at the end of the talk. The NHS in Scotland has always been had a separate basis in statute and its own structural and policy peculiarities compared to, say, the situation in down south in England and Northern Ireland, Wales. Once we move beyond the core principles of the NHS, which are shared, so free at the point of need, and so on, and kind of a universal service in terms of those that can use the service, the working realities of the service has become increasingly varied across the component parts of the UK, with contrasts and differences in terms of the structures and philosophies seen in the array of, for example, trusts, which come under the 2012 Health and Social Care Act, and this applies only to England. If you think about the fact that we have clinical commissioning groups in England, whereas in Scotland and Wales we have something called health boards. You might be familiar with interacting with your health board at some time in your life. If you're in Scotland and you live in Scotland and from Scotland. And the organisational integration of health and social care, which we see within Northern Ireland. Of course, we also have seen some developments towards that in Scotland in recent years through the health and social care integration agenda as well. There are a myriad of policy strategies which emphasise the divergences in approach to the specific polities. When I say polities, it just means countries. So Scotland, Wales, England, Northern Ireland. So if you think about in Scotland, for instance, The quality strategy is what drives a lot of the approach to health policy that concern the NHS. So the idea of quality improvement, the idea of ensuring that leadership approaches are applied to maximise the quality of services. For instance, there's also the 2020 vision that they implemented as well, which was linked to the integration of adult health and social care. This Scottish Patient Safety Programme, that's another example of a kind of national initiative that drives how the NHS operates in Scotland. But there's also in Wales, the Together for Health and the 21st Century Healthcare Strategy. But there's more, there's several of them. But these national strategies give you a sense of the priorities that policy have within different parts of the UK and the points of emphasis that can shape the way the NHS is managed. We can discern certain common features across some of the component entities of the UK. So the commissioner-provider split is common to England and Northern Ireland. The use of quangos in England, Scotland and Wales, quangos being quasi-non-governmental organisations. So for instance, in Scotland, we have Public Health Scotland, which is a quango of the Scottish Government that's responsible for health inequalities and health awareness provision and awareness raising about health promotion. In England, for instance, we also have agencies that, such as Health Security, the UK's Health Security Agency, which was recently reformed from Public Health England. Again, quite similar to Public Health Scotland. We've seen the organisational integration of all health services in England, Wales and Northern Ireland. It's Gray and Burrell in 2013 talk about this. And that's also cited at the end of the talk. So the key thing to take from this is when we're thinking about the NHS in the UK, the overall impression is of geographically specific reform agendas. Having said that, there are some commonalities in terms of ways of thinking about reform, and we'll get into that just now. The key underpinning question here that shapes the academic literature on developments in health policy from a managerialist perspective is about whether or not we've seen a rise in managerialism. And I think it's fair to say we have within the NHS, within health policy. Let's just look at some of the elements of what we mean here by managerialism, by taking a step back and thinking about it in terms of the frameworks which help us organise our thinking on this topic. So, the public administration and management field has seen considerable development over the past 30 years. Something called the traditional model of public administration is something that was heavily associated with the public sector in the post-war years up until the 1980s. An emphasis on a public sector that was quite bureaucratic, hierarchical. There was clear lines of accountability and control for the most part. And this shifted towards a new idea. I say new, but it was actually linked to the post-1979 election of Thatcher because it's heavily associated with Thatcherism, is the rise of the new public management agenda. The new public management agenda linked to ideas of neoliberalism, decentralisation, and rolling back the state-led approach. Rather than being interventionist, try and think about introducing a more competitive mindset to how the public sector works in a similar way to the sentiments of the private sector. This is linked to economic policy reform towards what we call monetarism and more of a free market economy thinking. The rise of new right ideology linked to Thatcherism led to what we call a paradigm shift from the traditional model towards new public management. Public administration academics became increasingly concerned with market mechanisms, as were policymakers. The idea of competitive tendering, not always getting the public sector to deliver services. In the 1980s, we've seen a big rise in competitive tendering within hospitals, whereby things like cleaning services, catering services were outsourced to private companies who could deliver for the lowest price. Sometimes that could compromise on quality. In later years, ideas of best value were introduced, whereby value was also linked to quality as well as price. But in the 1980s, we've seen a rise in this idea of introducing competitiveness into the public sector, all the way down to even how hospitals are run. Ideas of efficiency, consumerism, outputs, regulation, competition, performance management, and performance measurement became key terms that we would associate with this new public management idea about how the public sector should work. Although these terms have considerable scholarly currency, so academics like to talk about them quite a lot, new public management developments in the 1990s foregrounded the emphasis on perspectives such as governance that we talked about before, or even modernisation, which were aligned to the post-97 New Labour Blairite agenda. This agenda had its roots in Thatcherism and continued under Majorism post-1990, bearing in mind that Margaret Thatcher, her successor was John Major up until 1997, and after New Labour came to power under Prime Minister Tony Blair continued a lot of the thinking, a lot of the new public management thinking that was established under the Thatcher eras and continued by the Major government. The idea of consumerism, introducing competitiveness in the public sector, seeing the public sector as trying to move away from a monolithic approach to a kind of de-aggregated system. Perhaps you'll be reminded of the first talk when we referred to path dependency. Perhaps Thatcher created a path which successive governments have continued to apply in different ways and played with and adapted, but haven't fundamentally reformed. New Labour reforms included a focus on establishing foundation hospitals, a move which sought to promote semi-autonomous working, decentralisation, and local control. The idea of competitiveness. Academic debates gravitate around what could be the successor to new public management, what's coming next. Mark Moore's idea of regarding creating public value has emerged as a prominent interpretation of public sector reform, which calls for public managers to open up policy processes to rebalance power relationships, to give citizens a greater role in shaping decision making. So words like co-production, co-creation, deliberation, and getting the citizen to have a role in shaping how services operate. Public value does incorporate lots of new public management thinking, but perhaps has a greater emphasis on outcomes and getting the citizen to be part of the process. There's lots of debates in the literature about whether or not public value is really a new paradigm, or whether or not it is just a variation on what came before. Indeed, lots of authors argue that. One of the things I would say as well, that there's reading on this general topic that I would encourage you to engage with. But on the Moodle site, I've provided a link to a recent book by Arno van der Svets and myself on public value management, governance and reform in Britain, and it's available as an ebook from the library, which deals with a lot of these issues. So I'd encourage you to read that as part of your wider reading into the topic. So to help our understanding, what's the differences, if you like, or what's the points of emphasis that vary between new public management and public value management? This table here features in the book that I've just mentioned, but it has been adapted by Stoker 2003. So new public management, in terms of the key objectives of the system, the focus is on managing inputs and outputs in a way that ensures economy and responsiveness to consumers, highly focused on efficiency. Whereas in public value-based management ideas, the overall goal is about value, achieving public value. Therefore, the focus becomes more about effectiveness over efficiency, per se. Definition of public interest. Well, new public management ideas is about the aggregation of individual preferences captured in practice by senior politicians or managers supported by evidence about consumer choice, right? So consumerist approaches. Whereas public value management ideas has more of an emphasis on individual and public preferences produced through a complex process of interaction that involves deliberative reflection over inputs and opportunity costs. So bringing in the public's thinking into what should shape decision making. In terms of the system for delivery, new public management ideas focus on the private sector or tightly defined arm's length public agencies. So you've got a big department, say, a big UK government department, for example, they say the Department for Health. Back in the 1970s, you may have seen the department may have been a big, large, huge department, whereas private sector-based thinking would say, right, okay, let's disaggregate this organisation and create an agency that works at arm's length of the parent department so that it brings a degree of disaggregation, get it headed by a chief executive that perhaps works in the private sector, and therefore that brings a degree of managerialist thinking to how that operates, that department operates, and how the policy is shaped. Whereas public value management ideas would focus on a menu of alternatives selected pragmatically and a reflexive approach to intervention mechanisms to achieve outputs. So it's the idea of that there'll be a series of options, similar in a way, I guess, to kind of bounded rationality perspectives, but that would be a kind of reflexive approach to change, and that it's more of a reflective idea. Don't necessarily use the private sector if it's not the most appropriate. Use the public sector when you need to, but if you have to use the private sector, then fine. So, but don't have a default position. It depends on the context. So public value management ideas would not refute the role of the private sector, but it may be more selective in using it, depending on the issue at hand. In terms of a public sector ethos, well, under new public management thinking, public sector ethos is less favoured compared to customer service. Again, consumerism is the focus of new public management. Whereas public value management ideas is that no single sector has a monopoly on public service ethos. Maintaining relationships is about shared values rather than ethos, okay? The dominant model of accountability under new public management is the idea of the separation of politics and management. Politics is there to give direction, but not hands-on control. Managers are there to manage, and there's an additional loop of consumer assessment built into the system to help develop the system. Whereas public value management ideas is focused on elected leaders, managers, and wider stakeholders that are working together to find solutions to problems and to find the effective delivery mechanisms for solving those problems. The system, therefore, is subject to challenge through elections, referenda, scrutiny functions, and shifts in public opinion. The public manager. So what's the role of the public manager in new public management thinking? Well, they're there under new public management ideas to help define and meet agreed performance targets, whereas public value management, the focus is on the manager playing an active role, perhaps more of a leadership role in steering networks of deliberation and delivery and maintain the overall capacity of the system. So they work across boundaries, they work across partnerships, they build networks, they steer networks. So there's much more of a resilience and fragmented role for the manager, if you like, within public value management thinking. So what have we seen now? Have we seen the outcomes of new public management in terms of how we can see the way that health policy operates with a particular focus on the NHS? Well, the modern NHS, how can we capture it now? And how can we think about it from a developmental perspective? Well, it's doubtful whether Aneurin Bevan, who was the one that had all the ideas about setting up the NHS in the first place, could have guessed that the way in which the NHS would have grown and developed has developed as it has. He would have been very surprised. Few, if anyone, prior to 1980 could have confidently predicted the way in which public administration has developed as a result of public sector reform and the technological revolution in IT, telemetry, material science, and robotics. Complexity is a word that we can associate with the modern NHS. Is that an outcome of new public management? That's a big debate, but you can see how the reforms that are being introduced in terms of the thinking around how you approach the NHS has certainly seen considerable change in recent decades. But it is a system that can be characterised by complexity. There are complex lines of accountability and control, even those that work at the sharp end. For instance, if you're a radiologist or a nurse or a porter, you have a complex set of accountabilities. Perhaps that wasn't the case 30 years ago. Senior managers and professionals may be in charge, but it's difficult to see how they can be answerable or accountable in a meaningful sense for the actions of junior staff. And in turn, junior staff are often resentful of having to be personally accountable for mistakes that occur in a system that might not necessarily always be led in the most effective way. Can it be the case that the NHS can be overmanaged? You might have come across some debates about there being too many managers in the NHS. I'm not saying there is. What I'm asking you to think about is, what do you think about that? Is there too many managers in the NHS? Or is it the case that hospitals, services have become so complex that actually you require skilled managers and being able to actually join the dots, build capacity, and make sure resources are used in the best way? There are accountability issues. Even where they have line managers, it's often based in the NHS, for instance, on a complex matrix management system. And that can complicate accountability. I worked in the NHS for a national agency before I came into academia, and I can tell you that lines of accountability could be often blurred depending on what you're working on, because sometimes it was quite unclear as to whether or not you had full control. So was it central government? Was it community planning partnerships? Was it other wider services that actually were in control? Sometimes you had to manage your way through some of that, which wasn't always easy. But then you have to add the issue of the contracting out, the competitive tendering, and the marketisation of services. I've used the example of cleaning services here. So if something goes wrong with the contractor, who's responsible for that? There's big questions there. One of the things we've seen as well in terms of developments in health policy is, unfortunately, that performance measurement seems to be the dominant model over evaluation. So monitoring the inputs and the outputs of a service, so how much money that goes in and what's produced, how many patients are seen, how many doctors there are, and so on. That's often the focus of how success is judged, or failure even, within the system. But actually, we shouldn't forget the role of evaluation. Evaluation can tell you more about what works for whom, where, and to what outcome. It does happen. I'm not saying it doesn't. And evaluation has become more popular, but it's often not done in a sustained way. There's still a patchwork of evaluation out there, and perhaps the performance measurement, the focus on inputs to services and the outputs, forget that we need to answer the question of what difference has a service made? What difference has a health check program made? What difference had a medication made? These are things that we have to focus on. Because evaluation can give you the evidence about what really works in the NHS and what also works for the associated services that make a difference to the lives of people and communities. By way of a summary, so we've looked at part one by conceptualising the developments and how we can conceptualise how we view developments in health policy. We've looked at some of the issues around managerialism linked to new public management and public value ideas, and kind of had a snapshot of perhaps the outcomes of new public management in terms of, the way the NHS has become, the complexities, accountability issues, and the issues to do with performance measurement. I think it's fair to say, if we're to summarise all of this, there are different ways to view developments in health policy from a conceptual perspective. To understand developments in health policy, we have to understand new public management developments, as this helps us to see why and how managerialism is a key feature of health policy. Path dependency is important. The past shapes the future. What came before shapes what policymakers tend to do in the future. Just look at the reforms introduced by the Thatcher government in the 1980s and how that thinking has endured in many ways in terms of what has happened into the future through successive governments. The idea of, divergence within the system, disaggregation, decentralisation, despite it being a national health service. Developments in the UK is not exclusively a UK experience, and that's very important to emphasise. A lot of the examples that we've drawn down today have included global examples around the pandemic and health security and so on, but our focus has been on developments in the UK when we've been talking about the NHS and the constituent parts of the UK. But one thing to remember is there's more to it than the UK. If we think about the developments in other systems across Europe, the thinking about health policy from a systems perspective has seen a lot of currency across the EU, European countries and beyond. But also the ideas of empowerment, the ideas of decentralisation of services, managerialism, leadership and so on are common across European countries now. So I think it's important to remember that developments in the UK, although will have their own context and they will have their their own idiosyncrasies and elements that will be different because of the structural and path-dependent nature of the system, there are common ground here. There is some common ground here across how we can view health policy more generally from a systems perspective based on new public management thinking. And there's some more reading on the Moodle site with regards to that, so you can engage with it. So references in the slides here. So here's all the sources that I've referred to in the talk today, and from part one as well. These are the references I use. So please do follow up with these for your more general knowledge, and please consult the Moodle site for the further reading that I'd like you to do based on this talk, but also for the preparation required for the live introduction that we're going to have, the live discussion we're going to have in the class, where we talk a bit more about path dependency and health policy. So thank you for your attention. I hope you found this useful. I'll share a hard copy of these slides as well, so you have them, and I'll see you at the live session. Thank you.